We're looking at the hamstring muscles. We'll have a look at the mechanics of the muscle, how it works, and then how it's injured and how we can construct rehabilitation programs. So the muscles themselves then stretch from the pelvis to the knee and are divided into sort of a medial and a lateral component. So obviously laterally we've got our biceps and medially we've got our semitendinosus and semimembranosus. Now the biceps has, as its name would suggest, has two heads. So it's got a long head and a short head. The long head stretches from the pelvis to the knee, but the short head stretches from the femur to the knee. So we can divide these muscles up in terms of the way that they work. So the first thing to say is that from that previous diagram, it looks as though the muscle fibers stretch from the ischial tuberosity down to the tibia. But in actual fact, although that's the direction of the muscle fibers themselves are not fusiform, they are bipinnate. So what that means is the appearance of the muscle is a little bit like the barbs of a feather, where the sort of center part of the shaft of the feather would be the central tendon of the muscle, and then the barbs would be the fascicles. So there are advantages and disadvantages of this this setup for a muscle. So where the muscle fibers and the muscle fascicles, which are obviously the groups of the fibers, travel along the length of the femur, their pull is directly in line with the pull of the muscle from the origin to insertion. So that would be the sort of most powerful setup. However, the power of the muscle is dictated by the cross-sectional area. So if we were to cut the muscle across and we would look at the sort of stubs of the individual fascicles, we could count the fascicles and say, well, how many do we have across? And a muscle, for the sake of argument, with 2,000 fibers would potentially be able to be, to create more force than one with only 1,500 fibers, for the sake of argument. So where we have this angulation, this pennation of the muscle fibers, when we cut that muscle across, we will see more muscle fibers in cross-sectional area because they're angled. And so potentially the muscle is more powerful. So that would be the advantage of this bipennate configuration. However, each muscle fiber, as it pulls, is pulling at an angle to that central tendon. So that angle, known as the pennation angle, is obviously not directly in line with the femur. And so although you have a greater number of fibers in cross-sectional area, you sacrifice a little bit of the power because the fibers are pulling at an angle. And that angle of pennation will change. So as the muscle shortens, the angle of pennation will alter, and also through training the angle of pennation will alter. So it's normally around about 15 to 20 degrees. In bodybuilders it can go up to sort of 30 to 35 degrees. And that makes the muscle bulkier because it has a greater cross-sectional area, but doesn't necessarily make it more powerful. And the other thing to consider is that the angle of pennation will vary between individuals. So an individual may be stronger simply because of the architecture of the muscle itself. All right, so what about the central tendon? Well, the central tendon is where the force is transmitted to, and then obviously it's transmitted through the central tendon to the origin and insertion of the muscle. So, excuse me, so when we get an injury to that muscle, if it affects the central tendon, then however much force is created by the muscle fibers, that force can't necessarily be transmitted throughout the muscle itself. And so there's quite a lot of attention on injuries to the central tendon. And these are often assessed through MRI scans, and you'll see a variety of different injuries. So you can have a partial rupture where the tendon is continuous, but it's got a bit of a kink in it. You can have a full rupture where there are two sort of stub ends of the central tendon that will heal through fibrosis. Or you can simply overstretch the tendon, so the tendon ends up with a sort of a wavy appearance as it starts to heal. And originally this was thought to be something which is, very important, and certainly in elite sport where there's a central tendon injury, often that athlete would be sent for surgery. Now, there are a couple of considerations there. One is that the tendon will heal. So if we don't operate, but we leave that over a period of time, the tendon will heal. The second consideration is that when we judge return to play, athletes can return to play and be fully functional to compete, although the central tendon is not continuous 100%. However, on the flip side of that is that these modifications and this healing will take time. So with an elite athlete where time is, a major factor, surgery may be considered, not because the central tendon doesn't heal, but simply because it doesn't heal in time. All right, so those muscles then are stretching from the pelvis to the knee, and so they are by definition two joint or biarticular muscles. And we also have monoarticular muscles. So if we look at the hip extensors, we've got our gluteus maximus, which only works to extend the hip. But we have our hamstrings, which work to extend the hip rather, but also work over the knee. Whereas at the knee, we have single joint muscles. So the shorter head of the biceps, for example, or the vasti, the quadriceps on the front, compared to the rectus femoris. So we have two joint muscles which are an adaptation. So simply by taking two single joint muscles and saying, well, they have disadvantages, and joining those two single joint muscles together, we have an adaptation, and that adaptation occurs through locomotion. So it's seen in the upper limb, in the biceps and triceps, which will, would enable us to sort of swing through trees, as it were, in our evolution. And in the lower limb, the rectus femoris, the hamstrings, the gastrocnemius, which allows us to run quickly or to run for long periods on two legs rather than on four. So there are advantages and disadvantages to this. So the first thing is, in terms of the advantage, because the muscle is longer, as it contracts, it will move to a greater range of motion. So its contraction velocity compared to two single muscles can actually be lower. Secondly, it can generate greater force than two equivalent single joint muscles. So most mathematical calculations will say that it can create up to 3 times greater force. So why is this? Well, because when we look at the muscle, we have two parts to it. Firstly, we have the actin and myosin filaments, the overlapping filaments which will slide to create active force. But those active and myosin filaments are encased within a framework. So we've got our muscle fibers grouped into fascicles, the fascicles grouped together and surrounded by the endomysium, the perimysium, and then finally the whole of the group of the fascicles surrounded by the epimysium. So this connective tissue framework is highly elastic. And then at the end of the muscle, we have the muscle tendon, which is again fascia, and so it is elastic. So when we look at this diagram, we see that we have two force generating components of the muscle. The first is the sliding filaments, so the actin and myosin filaments, which can create force through active contraction. But then we have fiber, the connective tissue framework running in parallel, so the parallel elastic component, and then running in series, the series elastic elements. And so those will generate force through springiness, through elastic recoil. So when we're overlapping these actin and myosin filaments, when we're at mid-range, we can slide the full length of the actin and myosin filaments. When we're at inner range, we've used up most of that slide, so we lose the ability to generate force actively. And when we're at outer range, those fibers become disengaged, and so we lose the ability. So we come up with this length tension relationship where we say, well, the longer or shorter the muscle is, the less tension it can produce actively. And so we have a compensation for that, which is to say, as we move towards outer range, as we put that muscle on stretch, we can't generate force actively through contraction, but we can generate it passively through recoil. So we can still generate force, but we generate it in a different way. So it's a very clever adaptation. So when we take that adaptation and we look at the running gait, then we see that we're using that. So initially what we will do is we will swing the leg forwards through a hip flexor action. And then as that leg straightens and comes towards the floor, we will decelerate it. And that deceleration will occur through an eccentric action of the hamstrings. But as we get to closer and closer to the floor, eventually we end up with the muscle fully lengthened through eccentrics. And all that then happens is the remaining lengthening is through stretch, through elastic recoil. So we have an isometric contraction, no more force created through actin and myosin sliding, but the muscle is placed on stretch. So we have force created through recoil. So as our heel hits the ground, we've gone through a complex ballistic action. So the hip flexors have flung the leg forwards, the hamstrings have started to decelerate the limb towards the end of the swing phase, and then we have this stretch where we have an isometric contraction and the muscle is simply being stretched and generating force. And then, so that is complex. But then we have another layer of complexity where we say, well, as that heel contacts the ground, now we have a muscle which essentially is a knee flexor. Because it's placed on stretch, as the heel, the heel touches the ground, it will pull the leg straight, working with the quadriceps to lock the knee. So we have a paradoxical leg extension from essentially a knee flexor. So we've got a complex action with a complex muscle group formed of 3 different muscles. So obviously that can break down, and when it breaks down, that is when we start to see injury. So looking at these 3 muscles, then we've got the biceps, which is a muscle which has supplied by 2 components of the nerve, and has a long head and a short head, so it's relatively complex. We have the semitendinosus, which is more of a thinner tendinous muscle, and they have the semimembranosus, which is a bulkier muscle, and that reflects how we use them. So the biceps is more active as we accelerate during sprinting and right at the end of that swing phase. So it's placed under the largest strain of it's pulled, if you like. The semitendinosus develops the greatest lengthening velocities, and it's more active in high velocity sprinting, so faster sprinting. Whereas the semimembranosus, because it is bulkier, is the primary force producer, and so it's more active at initially generating power in the swing phase and in the stance phase. So as your heel hits the ground and you're flexed and you pull back through extension to propel yourself forwards, it's the bulk of the semimembranosus which is going to be causing that. But as you're in the swing phase and your heel is off the ground and it's whipped forwards by the hip flexors, and towards the end of that movement, as we decelerate the limb, it's more the biceps which is active. Okay, so that is our action in sprinting, and we've changed from running on 4 legs to running on 2 legs, and we've adapted to that. But now that we are on 2 legs, we need to reach down to the floor to pick things up, and when we do that, we use this adaptation. So as we bend forwards, we would expect to see an eccentric action of the spinal extensors and an eccentric action of the hip extensors, because those hip extensors are working to control the pelvic tilt and to draw us back. But what we actually see is something quite different. So we see, as we bend forward, that the spinal extensors work initially as we're lowering ourselves down, and as we get towards our end range, they stop working, and as we come up, they're no longer working. Initially, we come up on elastic recoil of the muscle, and then the spinal extensors come and work again. And that graph is similar, less powerful, but similar on the hamstring. So we have a flexion relaxation response in the hamstring. So we initiate the action through elastic recoil, and then the muscle starts to work. Okay, so we've got complexity of the what we call the strength shortening cycle. So creating muscle through springiness as well as contraction. So to summarize, then we have 2 joint muscles, biarticular muscles. They have an action over the hip and the knee, but they also have an action in lifting and pelvic tilt. We've got this flexion relaxation response. We have activity of the hamstrings, which is eccentric to decelerate the limb, which is isometric to allow the muscle to recoil, and which is concentric to help to stabilize the knee support. And then we have action in running, in jumping, in sprinting, in kicking. So we also have the differential between these muscles then, the semimembranosus thick and strong, semitendinosus thinner, biceps more complex. Okay, so we have an injury and we can categorize those injuries. So initially we can use the Munich classification, which is a method of categorizing injuries in general for all muscle injuries. So when we injure ourselves, we could have a direct injury. So we could whack ourselves on the thigh with, a heavy hockey stick. And when we do that, that can cause bruising, contusion, or it could split the skin and cause a laceration. So that would be a direct injury, and the force for that injury is external to the body. Now that's not commonly seen with the hamstrings. What we do see with the hamstrings is an indirect injury where the force for the injury is coming from the body. And that indirect injury could either be structural or it could be non-structural, a so-called functional injury. So in terms of the hamstring then, we're talking about posterior thigh pain. So overexertion would be our type 1 functional functional injury, if you like, in inverted commas. So it's not an injury at all. So we don't see macro trauma. We might see micro trauma, but we see a little bit of ischemia within the muscle, which may last for the workout or for the day itself, and that may progress to delayed onset muscle soreness. So fatigue-induced muscle ischemia or delayed onset muscle soreness would be a functional injury, which we would classify simply as posterior thigh pain. Now, that's affecting the muscle, but we can also get type 2, which would be posterior thigh pain, not affecting the muscle directly at all. So that could be related to the spine feeding into the sciatic nerve, so nerve root compression or nerve root pain, if you like. Or it could be muscle related, so we could have the nerve affected within the muscle as it travels within the muscle. So a change in the way that the nerve is conducting its impulses through compression, or the way the nerve itself is moving, so through elastic recall of the nerve or sliding, so-called changes in neurodynamics. So these are our functional injuries which cause posterior thigh pain, which may cause an alteration in how the muscle works through pain inhibition or through nerve conduction. And then we have our structural injuries, where the muscle itself or the muscle casing is actually injured. And we can grade that from 1 to 4, with 4 being, total rupture and 1 being a more minor injury. So it can be partial, it can be moderate, it can be, more severe. So a minor, a moderate, subtotal or complete tear. Now, it's those injuries which we can take and we can focus on more accurately using this British Athletics muscle injury categorisation. Now, this is useful in that it can guide our rehabilitation. However, it has 2 faults, or 1 major fault. It is based purely on the anatomy of the muscle. So we know that, the anatomy of the muscle may not be the only thing that we're interested in terms of functional outcome. But it's based on the anatomy of the muscle, and it requires an MRI scan, which we may not have access to unless we're in elite sport. But essentially it takes the Munich classification and says, well, okay, we've got this 0 to 4 in terms of moderate to severe injury. But we need more information to ask where about in the muscle is it actually injured? And that's essentially what the Munich classification does. So it says we will grade it from 1 to 4, but we will also grade it as A, B, or C. And that relates to the position of the injury. Is it within the muscle itself? Is it within the muscle and its connective tissue framework, or is it a central tendon injury? Because depending on the degree of injury and the position of injury, the rehabilitation will need to take that into account. Okay, so we have injury then to 3 structures which are interrelated. So the first one would be the muscle, and that muscle, so the actin and myosin filaments of the muscle, will heal through stem cell activity, muscle stem cell activity, so satellite cells, the stem cells of the muscle, and that will be maximal within about 10 days. Where we get injury which affects the muscle fascia, so the casing of the muscle, that will also heal, but it'll heal more through inflammation and fibrosis, and that, although it will peak around about 7 days, it actually continues and won't be at full strength until about 21 days. And when we look at the central tendon, that will heal in a similar way, so through collagen, but rather than fibrosis, it will initially heal with type 3 collagen, which will modify to become more functional, so more tendon-like, to type 1, but that's going to take time. That may take up to 6 weeks, which is why in elite sport we may consider surgery for some of these central tendon injuries. Okay, so generally then what we will see within that muscle is the muscle will try to protect itself, and so it's going to knit its sort of injured ends together, so we will see muscle fascicle shortening. We will see a reduction in hamstring activity. So the hamstrings will be going through a process of pain inhibition. So we'll see a reduction in myoelectrical activity. So on an EMG, you know, it's not just that the muscle is painful and the person is unwilling to contract the muscle, but it simply won't work because there's inhibition. The second thing that we will see then is the muscle activity will be reduced as the hamstrings work towards the terminal end of knee extension. So as we put that foot, that heel to the ground, the hamstrings won't want to work as much because they're trying to protect themselves. And we will see protective shortening around the hip flexors to try to reduce the load on those hamstrings. All right, so that being the case, we can see that on MRI, but how are we going to judge that if we don't have access to MRI? And also knowing that that is an anatomical consideration, and when we take a biopsychosocial approach to healthcare, we're not just concerned with the bio, with the structure, we're concerned with other things about how the person is reacting rather than how the tissues are reacting. So the history of injury will be important. So a central tendon injury will normally require a greater amount of force. So this is a sprinting injury or, you know, a slide injury. There's likely to be more bruising where the center part of the muscle has been injured and the framework of the muscle has been ruptured. So where we've got a muscle hematoma, that can either be within the muscle itself and contain, so an intramuscular hematoma, or it can come out of that center part of the muscle and it can spread along the fascial casing, so an intermuscular hematoma. And when it spreads, that bruising will occur in other places. So it'll spread down the thigh and it can spread into the calf. So it's following the casing of the muscle. So that will affect how much pain there is there, but that will also affect the function of the muscle. So we'll be looking at isometric holding to see whether the patient can actually hold or whether pain inhibits that. And if they can hold, how strong is that? And we use something called an eccentric brake. So we say, well, you pull against me, I'm going to pull, and you're gradually lowering that knee towards the couch from that prone position, and eventually you can't do it anymore and it suddenly gives. Now with a severe injury, we may even be able to palpate a gap. Now initially when we've got a lot of bruising, a lot of swelling, that gap may be filled up, but later on we may be able to palpate that gap. We can also judge outcomes to a degree by pain, and we would need to assess what the nerve is doing, so the neurodynamics. So looking at that and looking at pain, there's quite a useful questionnaire that we can come up with, which is illustrated on the next slide. But just to sort of categorize that and to sum up that then, our grades 1 to 4 and how we judge this without an MRI. So grade 1 is a small tear, so it's unlikely that it's going to stop the athlete from performing at the time. So they may feel a little bit of pain in the game or some pain afterwards, but it doesn't limit them. They have a normal range of motion by about 24 hours after injury, and they had minimal pain to contraction. So it was an annoying injury, but it's not limiting. With more of the muscle torn, so a moderate tear, a greater amount of pain, and it probably needs them to stop. So they might say, well, yeah, I tried to continue for 5 minutes, but I've got to come off. I've got to stop my training. There's some limitation to range of motion by 24 hours. So when we do a sort of straight leg raise, it's not comfortable. And when we do a passive hip flexion, it's not comfortable. There's pain and contraction of the muscle, but particularly as we start that contraction, so as initiation of the contraction, and there would be detectable weakness. So if we were to say, well, you know, normally it would be 5 out of 5 for strength, this would be a 4 out of 5. When we have a more extensive tear, then the pain onset is sudden. So the patient, the athlete will suddenly pull up, or they're jumping and they have to suddenly stop. So they might fall to the ground. So they can't continue. It's not just a question of, well, I might be able to continue, I might not, but oh, now it's getting a little bit of painful. Now it's bang, I cannot continue. I need to be stretchered off. They've got pain even on walking. The range of motion at 24 hours is significantly reduced, and they've got obvious weakness. So it may be a 2 out of 5, a 1 out of 5. And where we have a grade 4 tear, then that may be a complete tear of the muscle tendon at the end of the muscle or the central tendon. Sudden onset of pain, as with the level 3. Immediate limitation of activity, as with the level 3. Possible palpable gap, but interestingly enough, there may be less pain. So that would be where, you know, the MRI scan would come in useful. However, if we don't have that, we simply need to recognize that that type of injury is going to take longer, and we would get that information as we go through the rehabilitation process. So, you know, we don't necessarily need to make that decision immediately because we're going to go through a rehab process. Right, so this is our FASH questionnaire then, the Functional Assessment Scale for Acute Hamstring Injuries. And it consists of 10 questions, and each of those questions has a 10-point score. So we get a total score of 90, so it's a percentile that we've got. And it's useful to assess different stages of rehabilitation. It's a validated scale, and it's useful to assess injuries between individuals within a team. So essentially it's looking at what we've covered down. So the first thing is to say, well, what level of pain or discomfort do you have? And then what limitation do you have in terms of your physical activity? So that's important because it's testing function. And then we get more specific and say, well, okay, you've got these levels of pain and change in function. How does it affect you when you're walking? What about jogging or slow pace running? What about acceleration or sprinting for 30 minutes? So obviously, if these are very painful, we're not going to get them to try this sprint. But if these are not painful, we might assume, we'll say, well, there's very little pain, there's no pain walking, and they can jog where you find play. Well, no, we would need to test that further and say, well, okay, you're fine at slow pace, but what about sprinting for 30 meters? What about acceleration, deceleration? Okay, what about bending into a stretch position and coming back? Because we know that hamstrings are important for running, but they're also important for bending. What about swinging the leg? So a straight leg kick. So we said that hamstrings are important for running, but they're also important for running, for bending and for kicking. So we need to get information on that. And then we go on to other functional movements. So a lunging type action is obviously working a 2-joint muscle. So we're stretching the hamstrings at the hip, we're shortening the hamstrings at the knee. You know, can you do a full weight bearing lunge painlessly, or does it hurt? And that gives us information for rehabilitation later on. So we can say, well, you know, if this person's got an 8 out of 10, well, the rehab that we design is going to be different than the patient who has 1 out of 10. And then we come up with our Nordic, which is we'll talk about later, and say, well, can you do it at all? Now, we're not going to try that if they can't do any of the previous things. But if they can do that, we know that the ability to perform a Nordic action is predictive of injury. And then finally, if they can do all of that, we say, well, can you actually jump on it? Can you do 3 one-legged jumps? So these are more functional tests. And then we've got that score and say, well, you might say your pain is reducing, and you might say you can run, but your FASH score was 48 to start with. Now your FASH score is 70. We actually need it to be arbitrarily 85% or whatever you decide for that particular individual in terms of motivation. Okay, so what do we need to consider then when we're looking at rehabilitation? Well, we've looked at a lot of things. So do we need to consider biomechanics? Well, we may need to if it has changed as a result of injury, and that would be biomechanics of the action of bending, so lumbopelvic biomechanics, biomechanics of the lower limb, so are they doing something different when they're leg on a squat or a deadlift or whatever, or biomechanics of the foot, have they compensated for this pain? And you couldn't see them immediately, you saw them 3 weeks later and they've been limping around, and so they've changed their biomechanics. So that may be something which is important, and that would be a secondary effect to the hamstrings, but nevertheless still important. We're going to look at neurodynamics, so we can look at the straight leg raise and the slump test, and we'll look at that later. Then we're going to look at the neuromuscular control of the pelvis. So, we're on to sort of core stability here now, which is not used as much nowadays as it was in the 1990s, but it certainly isn't irrelevant. And again, it would be important if it has changed, because we're going to be putting this athlete into lifting situations where if they don't have lumbopelvic control, we could actually be setting them up for further injury. We're going to do some form of eccentric biased strengthening, because we know that we have fascicle shortening, and eccentric biased strengthening can result in re-lengthening of that shortened fascicle. So that would be important. When we return them to running, assuming that the running is part of their sport, we're going to do that progressively. And this is, I think, a mistake that sometimes is made, where people will rehabilitate in a gym and then say, well, okay, you're fine, you've done your Nordics, you've done all this, off you go for a run. That needs to be as progressive as our squats, our deadlifts, our RDLs, etc. So that would need to be progressive. And then stretching, is it a consideration? Well, we know at the end of a forward swing, they're moving into a stretch position. Now that is eccentric lengthening, which is important, but it is also isometric and then stretch of the muscle. So if they've lost range of motion, we may need to rebuild that. And again, that would be a progression. So you might start off with static stretching, go on to more dynamic stretching, go on to eccentrics. So it doesn't necessarily need to be a stretching exercise. An eccentric activity is stretching the muscle, but we need to perform a needs analysis and say, well, what does that athlete actually need? Because clearly a hurdler needs more flexibility than a sprinter, who needs more flexibility than a lifter. So we would need to format the rehabilitation accordingly. Okay, so this is our slump test then, and this is useful obviously to differentiate the posterior thigh pain. So we've said, well, you can get posterior thigh pain from a hamstring injury, but you can also get it from a non-functional injury, in inverted commas, so something which is affecting the sciatic nerve. And that may be affecting the sciatic nerve from the nerve root in the lumbar spine, the sacral spine, or it may be affecting the sciatic nerve within the thigh itself. So in this stretch position then, I'm stretching the hamstrings, But if I put an extra stretch on at the foot and an extra stretch through the spine, obviously I'm stretching up the whole of the neural system. And the neural system is continuous, isn't it? From spine to sciatic nerve to tibial nerve, etc. So if that posterior thigh pain is relieved by getting into this position and then looking up at the ceiling, well, clearly I'm releasing the neural system, but I'm not affecting the hamstring. So that would be indicative of involvement of the sciatic nerve. And it's unlikely to be one or the other. It's normally going to be a combination of the two. It would only be the sciatic nerve in isolation if it was, resulting from impingement at the lumbar spine. So they've come in with, back pain and pain in the thigh, so sciatic type pain. But where we get a hamstring injury, because the hamstrings essentially are lying on top of the sciatic nerve and supplied by the sciatic nerve, it's likely that the sciatic nerve will be involved. It's just whether it will recover spontaneously or not. And we can use this type of movement to rehabilitate the neurodynamics. So we can perform a lengthener where we simply say, well, I'm putting the whole of the system on stretch. So I'm stretching your hamstrings, but I'm also stretching all of the nerves in the lower limb, through the spine and in the upper limb. And we can do a slider. So we can say, well, if I release the stretch at the foot by plantar flexing, the stretch is more in the upper body. And then if I keep this dorsiflex, but I look up at the ceiling to release the stretch and the upper portion, the stretch is more lower down. So we can get to a degree, we can get a slide of the nerve and a slide of the spinal cord on the denticular sort of ligaments, and get movement. And if that movement has been reduced as a result of injury, then we would need to rebuild that. Okay, so neurodynamics then it becomes important, and it would be a progression from finding that there is a fault on the slump right up to using an eccentric action prior to a concentric movement. So-called stretch shortening cycle, where we're moving into a stretch position from a contracted position and linking that eccentric action with that isometric action and that recoil. So a plyometric rehab would be a final sort of progression, if you like. And then in terms of neuromuscular control of the spine, well, it may well be important because the hamstrings obviously attach to the ischial tuberosity, but the fascial membrane coating attaches through onto the sacrotuberous ligament. So it does have a stabilizing function to the pelvis and to the lumbar spine. So it may well be that, trunk work, trunk performance is important. And that would be to a sit-up type movement or to a forward bend type movement. But equally in single leg standing, so a Trendelenburg test, if positive, if we're going to be doing running and jumping and hopping, we need to enhance that stability in single leg work prior to doing that. Otherwise, we're rehearsing an incorrect movement, if you like, or a suboptimal movement and leading them likely for injury. So we're going to progress all of that onto our change of direction drills, our agility drills, our fast sprinting, etc. But in order to do that, we make sure that we get the basics right before we move on. Okay, so we've got a couple of different exercises which are commonly used then. So this is our Nordic, which is a knee dominant exercise. And we know that using this has been shown to reduce the incidence of injury. So using it as a prevention can reduce the incidence of injury by, about half. So it's obviously very, very important. It's building eccentric strength, and it's been shown to increase the fascicle length of the hamstrings, or the bit of the hamstring which is important for that terminal end phase of swing, so the long head of the biceps. And it used to be thought that we would need to do this daily, but that's now been modified, and we see that the increase in strength and the increase in fascicle length is possible by low volume programs. So, you know, twice weekly 4 reps is probably enough, certainly for maintenance. So we can modify this, and we can say, well, it's, you know, later on in our training it's going to be resisted, but early on it may be assisted. So she's using this gym ball, or she could use a pulley or an elastic band behind her to help with that movement. And that is a hip hinge type movement with the knee flexed. And obviously we can then progress that to other movements, hip hinge type movements with the knee straight. But a Nordic is a good exercise, but it's not the only exercise. So it will certainly give, you know, a high amount of work to the long head of the biceps, but we've got other things that we can use which will be more functional, and you know, so this type of hip thrust movement can be very useful because it's working the hip, it's working the knee, and we can move towards a more straight leg position and perform that isometrically. This type of hip dominant exercise, then, you know, straight leg deadlift, Romanian deadlift, RDL can be useful. So we've got squats and lunges and hip hinge type movements that we can use, and all of these are useful for different reasons and will put different loading on different portions of the hamstring. So essentially we need to mix it up. And we've got a couple of examples here. So this is our glute hamstring deck, and that is, you know, he's performing an isometric action. So he's simply holding that and moving the weight up and down in a chest press type movement, or a chest row, and he's building up holding time. He could equally well just go down and come back again to build up the hip extensors and the spinal extensors. So here we've got this bridge position. He's performing it with the knee bent, but he can slide further out this way until his leg is almost straight. And then he's mimicking what we would do at the end of our swing phase in running. So we're saying, well, it's eccentric to start with and then isometric. So that's essentially what we can do. So he can go from that high position and he can lower down and hold that lower position. So we've got a variety of different movements, and these are easier to perform. Well, for a start, you don't need a training partner, so they can be performed by the athlete themselves in the gym. They can even be performed at home. So, you know, they're simpler and more functional to a degree because they're mimicking what the athlete is doing. So let's not just stick on a Nordic. So we've got these exercises, and what they will do is re-lengthen the shortened fascicles. So we said that the fascicles, as they're healing, will shorten. This will re-lengthen them. And it does that by increasing the sarcomere length, the fascicle length, rather than adding more sarcomeres, and we can judge that, and we can judge sort of pennation angles and different things through ultrasound scanning, so we can actually see what's happening within the muscle. So here we have our hip dominant movement, and we can just perform a deadlift, or we can perform a single leg deadlift, or an arabesque type movement, or a Romanian deadlift type movement. So we can mix that up, and that is going to be loading more on the proximal aspect of the hamstrings, whereas a knee dominant exercise such as the Nordic is going to load more towards the knee, so the distal part. And we've got a variety of different exercises, you know, and they're not necessarily better or worse. We would perform a needs analysis to say, well, okay, what does that athlete need at this particular stage in the rehabilitation, and how are we going to achieve that? And then we move that on. So we're training for slow strength, we're moving that speed up a little bit against the resistance, and then we're training for power, and then we're lightening that resistance to body weight, and we're training for speed and change of direction and then agility. So we're progressing that through our various fitness components. and we've got an example here. So this would be performed as an isometric hold, simply in that bridge position, or we can go from eccentric to isometric, so she can use these slide discs to straighten and bend the leg, or a resistance ball, or the bench as we've seen previously. Okay, so we've got a variety of different movements here, and here we've got things which you can perform at home. Arabesque again, slide border, and all we're doing on this one is mimicking the original injury. So if they slid on a wet pitch, well, if your back foot is fixed and you put the slide disc under the front foot, you're mimicking that. Or in this case, you've got the slide disc under the back foot, and you're mimicking the sudden stretch on this front leg by body movement. So the so-called extender, so active straight leg raise, the diver or the arabesque, and this one the glider, or this front splits, and that's the sort of the protocol. So finally then we go on to running, which again would be progressive. So early on we're going to say, well, just walk. You know, if you're just doing isometrics in low grade, once you can do that, once you can walk, then we can start you running, and that running parallels what we're doing with manual resistance and slow activity in the gym. As we start to increase that and we do Nordics, so the and RDLs, so the running increases. So we're now doing running on a treadmill and varying the speed, building up the speed within sort of tolerance, and within, you know, starting to run outside, increases in speed as we start to do heavier weights in the gym, and finally as we move on to our plyometrics and our agility work, we introduce change of direction, acceleration, deceleration, zigzag running, cone running, T-tests, for example. So we're progressing the running at the same time as we progress our weights. All right, so if you want to follow up any of that in terms of references, a couple of references here, papers that I wrote on hamstring injuries, sort of part 1 and part 2 for Co-Kinetic Journal. And then there are some references in the sort of hip and thigh chapter of my sports injuries book. And then finally, just the standard sort of slide for contacts on social media, etc. All right, thanks for watching.